Hello, my name is Dr. Sarah Walker, and I'm honored to serve as the 2025 President of the El Paso County Medical Society. On behalf of our organization, I want to welcome you and thank you for tuning in to the El Paso Physician. For the past 28 years, the El Paso Physician has been dedicated to serving our community, and we are grateful for the continued opportunity to bring this program to you on PBS El Paso. This would not be possible without the generous support of our community sponsors who help us produce valuable content every month. If you or someone you know is interested in supporting this program, more information is available at 915-533-0940 or at epmedsoc@aol.com. Thank you again, and we hope you enjoy this program presented by the El Paso County Medical Society and hosted by Kathrin Berg.
What exactly is a trauma center? And really, what exactly is a level 1 trauma center? It's a big, big deal. I know, unfortunately, in El Paso, in our region, we have suffered some major trauma over the last several years. And thank goodness that we do have a level 1 trauma center and also a level 1 medical team that not only saves lives, but more importantly, addresses the long-term impact that patients have and their families have. This program is underwritten by University Medical Center, and we also want to thank the El Paso County Medical Society for bringing the show to you. And you may notice that we are in a new filming and taping facility. This is actually the home to the El Paso County Medical Society. It is a Trost building, a Henry Trost building that was built over 100 years ago. And the El Paso County Medical Society has been housed here from 1966 on, and they have their board meetings here and powwow meetings, but it's a great place to be. So welcome to the Turner home. I hope that you enjoyed this program. I'm Kathrin Berg, and this is the El Paso Physician.
Neither the El Paso County Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Hello, thanks again for joining us. We're going to speak tonight about what happens inside of a level 1 trauma center. What exactly does that mean? With us today, we have a veteran, and I say this because we've been doing this program at the El Paso County Medical Society now for 28 years. And Dr. Tyroch, I just found out from you too, and we're gonna have some fun with this. Dr. Tyroch came to El Paso in 1997. That's the year my daughter was born, and she was in a little cage. And I remember a cage, the little carrying cage. But you were that guy. So welcome back to the show, and thanks for not leaving. We appreciate that.
Thank you.
Dr. Alan Tyroch is Chief of Surgery and Trauma Medical Director at UMC. He's also professor and founding chair of surgery at Texas Tech University Health Sciences Center. And the guy that hired him is Dr. Leo Mercer, and thank you for doing that. Dr. Leo Mercer is the Associate Trauma Medical Director at UMC and also the Associate Professor of Surgery at Texas Tech University Health Sciences Center, El Paso. That's always so much to say. You're gonna be even more fun. And then we have Dr. Tiffany Lasky, and you have several titles. Dr. Lasky is the Pediatric Trauma Medical Director and also is the Associate Trauma Medical Director and is a Professor of Surgery at Texas Tech University Health Sciences Center, El Paso. I think we rehearsed that a little bit, and I hope I got that all right. But tonight we're going to talk about some ugly stuff, but we're also going to talk about how and why it is so great that El Paso has the UMC Level 1 Trauma Center. So what I'd like to do first, before we do anything, and Dr. Tyroch, even though I said to the audience what your title is, and for both of you, all three of you, I'd like for you to kind of let the audience know what it is that you do on a daily basis. I know that's always the hard one.
Sure. Well, I guess I can start. I was on call last night.
Oh, geez.
In the hospital.
Okay.
So we take in-house call and with our residents. It's a big team of people, not just surgeons, but nurses and respiratory therapists, different specialists. So whatever comes through that door, we deal with. And we see a lot of patients in transfers all over, not just El Paso, but southern New Mexico. I think last night we had probably about 7 or 8 people coming to us in transfer.
Oh my gosh.
Probably about half of those come by helicopter.
Okay.
So we see a lot of helicopter transfers, but we're very busy. Car wrecks, people falling down. I think somebody fell off his horse. We had surprisingly 2 people fall off their ladders. We were very busy with ladders this week. So
and it's not even Christmas light hanging
we
time.
usually get that, yes, in the wintertime.
Jeez. What I'm going to do, I'm writing notes here because I want to go back to that as well, because when we talk about the level 1 trauma center that you have here, it really is for a big geographical area. So Dr. Mercer, so you coming back to El Paso, you're in El Paso, and then you left to go to Australia for a while. Did I understand there? New Zealand. And then you came back. So now what do you do all day, every day in your role in El Paso?
The same thing.
The same. Okay, next. No, but it's
no. I mean, Alan and I and Tiffany work closely together. We're all quite busy. We see the same demographic, with the exception of Tiffany, who, from an administrative standpoint and guideline development, works on the peds side. Mm-hmm. I work primarily on the adult side.
Okay.
But clinically, we see the same sorts of injuries, the same types of patients, the same sorts of transfers and things of that nature.
And we're going to get into some, and I know every time we've got Tyroch again on the show, there's always these stories that just leave me with my jaw on the ground, just like, they did what? So we're going to hear a bunch of those stories today. And again, Dr. Lasky, you work more with peds than everybody else on this panel right here, but do you have like not a daily routine? That's not what I'm going for. But again, just so that people that are listening at home or in their cars, wherever they are, can know what it is that you do.
Yeah, I think one of the interesting things that really attracted me to trauma is that you don't just do trauma. You're a surgical intensivist. You work in the intensive care unit. And so not only are you in the emergency room and the operating room and all of the acute care things that we do, but we also get to spend time in the intensive care unit, and that was really my first love in medicine.
And I love that you brought that up. I know in the opening statement we talked about, yes, saving lives, but also the long-term impact of what happens. And again, with trauma, it's not like something you can cure it and you're done. I mean, this is something that lasts and goes on for years and years and years. And I know that your team at UMC has a lot of that put together too. So what I'd like to do, and Dr. Tyroch, I'm going to start with you because I'd like to explain what a UMC Level 1 trauma center that's verified by the American College of Surgeons. Like, why is that so important? Because you hear trauma center here, but there are different levels and there are different types of trauma centers. And I'd love for you to educate us on what those are.
Sure. So there's 4 levels of trauma centers. In Texas, there's 296 trauma centers total. 1, 2, 3, and 4.
Wow.
But the highest level is level 1, verified by the American College of Surgeons, and then designated by the state of Texas. So we've been a level 1 since 2001. We are actually also designated in the state of New Mexico. The only other level 1 in New Mexico is up in Albuquerque at UNM. So we cover a big area, 44,000 square miles, 1.25 million people in far west Texas and southern New Mexico. But we're a level 1, the only one for 270 miles. The next nearest would be up in Albuquerque, and in Texas it would be, I guess, Lubbock, 340-something miles from here. So we are an island to ourselves.
So when you say you cover 4,000 miles, even though there are these other trauma centers, there's only certain things that you all do that other places don't do, like Albuquerque. Like Albuquerque and El Paso, if you were to compare between the two, because it's a 4-hour drive.
Plus, at least.
And then helicopters, et cetera. So how is El Paso different from Albuquerque?
Well, they're similar in reality, because they're a big city, just like we are, but actually the population of El Paso is bigger than Albuquerque.
Right.
But
and we're closer than
and we're
a lot
closer
of
to
other
all
places.
the other hospitals and cities in southern New Mexico.
Okay.
So these are small hospitals. Most of them don't have operating rooms. If they do, they don't have surgical capability. So 43% of all our trauma patients that we see about 3,900 trauma patients per year that we admit to the hospital. About 20% are kids. About 24% or so are geriatric, meaning 65 or older. So we see all ages. And these hospitals just cannot take care of them. So they come to us in transfer. It's about 43% or so come in transfer that we see.
So that's a great transition, Dr. Mercer, in talking about transfer. So I know we joke, it's like, well, everything that Alan does, you do too. So when you have transfers, you've got helicopters for the most part coming in. Number one, who deploys the helicopters? Is there a medical center and or hospital in, let's just say it's Deming. Let's say it's a place that's pretty populated, but it's still far away from anyone else. How is the dispatch first made? Helicopter gets there, they get to you, or are you even involved with any of that? Or is it just once they hit the ground in El Paso at UMC, that's when things get going?
Most helicopter dispatch is handled either by the local regional 911 center, although hospitals can call them directly. Helicopter services are largely provided by private companies that have a contract with whatever organization, hospital, county, region they're contracted with. But that's the communication.
Okay.
We're not involved in making those arrangements. We don't have our own helicopter at UMC.
Okay.
So most of that comes from about 45% of it comes from of our transfers in from New Mexico come by air.
Okay.
We have a local based helicopter, Firestar, which represents a collaborative relationship between a private company and El Paso Fire Department.
So pardon my my laymanness, but when you think of different TV shows that we're watching, and they're medical shows, and it's like, okay, everybody go meet on the roof because the helicopter's coming. Walk us through what happens once the helicopter comes. Hopefully there's some kind of communication with the person that's in the helicopter with the patient that says, okay, here's a little bit of a heads up of what's happening. But walk us through that, Dr. Mercer.
I wouldn't know because I don't watch those shows.
Okay.
But
Really? Not a one?
No.
Did I ask earlier if he cracks a smile or not? But I believe you.
Sporadically.
I believe you.
Sporadically, right. No, we get a communication from their dispatch center. All of these individual helicopter companies have their own dispatch center, and they communicate with us what their inbound time is. And we're alerted. And if it's a level 1 trauma transfer, then the team is activated.
So I like that. I'm going to start using that word too, a trauma transfer. And Dr. Tyroch, you said about how many, what's the percentage of transfers? Because that was a large number.
It's about 43%.
About 43%.
Some come
That's
from
huge.
El Paso, the other
Okay.
hospitals in El Paso.
Okay.
We get ones from Alpine, Marfa in that area.
Las Cruces, and I
Oh,
know
a
that
lot
we
from Las
can talk a little bit. I
Cruces.
know that there was recently the
Shooting
pretty
there,
massive shooting in
unfortunately,
Las
yeah.
Cruces.
15 people.
And I'd like to talk about that because I don't think people understand, even though Las Cruces is there, yes, there's some hospitals there, but transferring everybody that needed that type of care to El Paso. Just walk us through that night, if you could.
Sure. It was a Friday night, if I recall, around 11 o'clock or so. I got a call from the surgeon on call at UMC saying, we got a mass shooting in Las Cruces. We're getting 3 victims. So I contacted a couple other trauma faculty and our surgery residents, and they all came back to the hospital. And I think we received 7 victims that night. And of those 7, we operated on 3 of them emergently. So 3 out of 7.
And so walk me through also, because there are only so many surgeons.
Yeah.
Right. And so when somebody has to, when you're in this situation, you've got incoming 7 people, and then the evaluation process. And Dr. Lasky, I'm just going to turn things over to you because you haven't been able to talk for a while. So, and by the way, on this program, feel free to bunt back and forth to each other. I love that. But once you have a certain number of people coming in and you're looking at the trauma center, how does the evaluation process work? You know, and maybe there isn't a lot of information coming in because you have a lot of people coming in. How does that, walk us through how that would occur?
So we have varying levels of traumas, and patients that are the sickest would be what we call level 1 trauma. So they would have low blood pressure, high heart rates, physiologic signs that indicate to us that they're in shock or that they're sick. And so those patients would get the highest priority because they would be the most likely to have to go to the operating room. And we'll deal with those patients first, and then we'll work our way down the rest of the list. And we'll have varying amounts of levels of trauma in an MCI or a mass casualty incident. So if you have an influx of, say, 7 patients from Las Cruces, there'll be a varying degree among those patients. Some will be level 1s, like the 3 that went straight to the operating room, and then there'll may be varying other types of patients, maybe a level 2 or a 3 patient, depending on what their physiologic status is.
And you were talking to a bit ago about intensive care. And so there's the night, whatever that night or that day is, when surgery occurs, things try to get as puzzled back together and matched up and fixed as possible. But now we're looking at the recovery time. And recovery from a heart attack is very different from a recovery from a gunshot. And since we're talking about gunshots now, but then we'll get into some of the other very interesting stuff that you guys deal with too, is trauma docs. So intensive care, there's that whole team is what I'd like to do. I know that we've got 3 MDs on the table, but then we've got the nurses that specialize in certain types of recoveries. Maybe talk a little bit about what those roles are. And I know it's anywhere between a couple of days to sometimes somebody can be in the hospital for a year. Hopefully not, but how does that usually go down?
So once the patient's done in the operating room and they don't need any further intervention that night, they'll usually go up to the intensive care unit if they're one of those level 1 patients that needs to continue to have blood or fluid, or a nurse that's going to give a 1-to-1 or 1-to-2 ratio. Our nurses are really facile with working between cardiac and neuro and trauma, but our surgical intensive care nurses are very good at trauma, and that would be kind of their specialty.
That's their specialty.
Or more their area of emphasis, where they practice the most.
Okay.
I think one of the things I always want to emphasize, trauma is a team sport. It's not just the 3 trauma surgeons that are here. You know, that Friday night with the Las Cruces shooting, one of the guys that had to go emergently, our hand surgeon, Dr. Diamond, took him to the OR. But we can have neurosurgery coming there, all the orthopedic surgeons, the oral maxillofacial surgeons, plastic surgery, et cetera. But you also have to have the anesthesiologists and CRNAs and the various specialists, PT, physical therapy, occupational therapy. So it truly is a whole group of people just for a level 1 activation.
Right.
There's probably about 14 or 15 people that come into the trauma bay, including blood bank and laboratory, x-ray, and then CAT scan people, CT techs, are standing by waiting for us to go there. I think we were running that evening 2 CT scanners at once just so we could move the patients through the process.
And then once they get out of the OR, there's respiratory therapy, and we have a pharmacy PhD, and physical therapists, and social workers, and the list goes on.
Dr. Mercer, you would say?
We talk about it as a team sport, and I've kind of expanded that. It really takes a village to do trauma well. We have trauma teams, but we have other people, other teams, to where it really involves so many people that it really does look like a village. When I started in doing trauma, it depended a lot on me, and that was kind of the nature of trauma 35, 40 years ago. Now, we tend to value what I call pit crew values rather than cowboy values.
So explain those two. Pit crew
Pit
values.
Crew, if you look
Again,
at
everybody comes in.
Everybody has, car pulls into the pit, needs new tires, fuel. Everybody's assigned a job, and everybody does it. And the degree to which they do it safely, efficiently, timely, then it produces a good outcome. If you don't, if any member of that team forgets to tighten a lug nut on a tire, the first turn doesn't turn out well, so to speak. So it is kind of an orchestrated approach to delivering trauma care. To the extent that it works well, it's a symphony. To the extent that it sometimes goes off the rails because we can't always predict what injuries patients are going to have. Occasionally it looks like a cacophony, but that's the nature of what people like Tiffany and Alan and I do, is to try to control that and make sure that the patient is safely cared for.
So listening how this pit crew kind of comes together, what brings to my mind is back in, I understand, 1998 or so, was the desire for the process to apply for a level 1 at trauma unit. And I know that takes a lot, but I think it's important for the audience to know what a big deal that is. So everybody on that crew has been tested, tried and true. You know that those people are going to do their thing. That is a level 1. How, Dr. Tyroch, when that time frame was coming together, how and what was the process of applying for, if that's even the right word, of being accredited as a level 1? And again, this is with the American College of Surgeons.
Correct.
So that's the entity that sends
They
this
verify
out.
us, and the state of Texas designates us, and they base it on what the college says.
Okay.
There's like 100 and something requirements you have to meet, maybe more actually now. So going back historically in the mid-1990s, the state of Texas said, we want a Texas trauma system. And there was also some money for hospitals to become trauma centers. So Thomas and General Hospital, which is what we're now UMC, they chose to go that route because most county hospitals wanted to do that so they could get some funding for indigent care. So, and that's why I came here, to help develop the trauma program at the county hospital. We became a level 2 trauma center in 1998. I probably didn't have much to do because I came here in late 1997. They had already started all that stuff. But as soon as we were a level 2, we said, let's go for level 1 status, which requires more academic stuff, research. Actually, you had to have an MRI scanner, which we did not have back then.
Oh, wow.
Yeah,
Okay.
we would get an MRI, portable MRI would come once a week to us.
And this is 1998.
That was probably 98,
1999.
99.
Okay.
So then we
Okay.
worked in those years from 98 to 2001 to become verified. And that's what we did back then.
Okay.
And we've been re-verified every 3 years or so since then. Now, these two actually were trauma directors at their places, so they know the process just as much as I do. So when they both joined me to go for our 2021 verification, 2024 verification,
Wow.
it was a big asset for me because they knew what needed to be done for
Right.
that. And it's a lot of work. It's not just us three doing this. Our trauma director, meaning Lydia and then Sandra Gonzalez at the time, they spent so much time putting a document together. It's probably about this thick.
I remember preparing for the program, and it might have been 2001, 2002, when you all were announcing this new designation. And I remember receiving via email the laundry list of things that you all had to have checked off.
Yeah.
And I thought to myself, I have no idea how I'm going to go through this list on the program.
Yeah.
But we kind of did it.
And it's grown since then.
I'm sure it has.
Yeah, it's more sophisticated.
And I remember going through, it's okay, there's 100 here, but let's take the top 50. From the top 50, what are the top 20 that people are going to be most interested in? And it's trauma, everything from, again, we're talking about gunshots, blunt force, car accidents. And I remember saying this too. You said to me, I said car accidents. They're not car accidents, they're car wrecks.
Right. Car crashes.
Car crashes. So I would like to right now use that as a transition because car crashes is where people get messed up. And a lot of other places, ATV crashes that we have here
too.
as well.
Oh, God.
Yeah.
And
I think you
motorcycles
said
are big
that
right
was-
now.
Okay, big right now. So
Well, I think
there's-
always big, but we had a rash of them lately.
Okay. It's getting warmer. Everybody wants to go
The weather's
outside.
getting better, and Texas is a state that doesn't really mandate the use of helmets.
That's right.
So, so there's a lot of things that come together from a systematic standpoint that contribute to morbidity and mortality associated with motorized vehicles.
Right.
It is not just young people on motorcycles. We're seeing 60, 70-year-old guys riding motorcycles that are on various agents that, because they had a history of heart disease or stroke, they're on what we call blood thinners.
Right.
So when they crash, they bleed into their brain or their liver bleeds more. So then we have to reverse it with various chemical agents or clotting agents. So it's not just some young guy.
Yeah, exactly. You know, somebody said, if you want to live a long time, just stop doing stuff. I'm like, yeah, but
you
where's
gotta
the
live.
fun in that?
Yeah.
Where's the fun in that? What I'd like to do with, again, crashes, wrecks, when someone has a blunt force trauma, and let's go away from shootings for a while. They
That's a
come into
small
the-
volume. Actually, the shootings and stabbings is about 10%.
Yeah.
All the other, people think, well, it's a knife and gun club at UMC. No, it's not.
Yeah.
It's old people falling down. And in all honesty, it's old people, right? Falling down,
ladders. Yeah.
climbing trees, or young people falling down, kids
Okay.
falling down.
No, I'm glad we said that because I could bring up the whole August 3rd thing, and I do want to address that in some ways, but to your point, that's not where the mass issues are that you're
just
having.
last week we had a 95-year-old come in. Actually, it was yesterday.
Yesterday.
95
Fell and hit his head. Went to the OR for a subdural hematoma.
Fell walking, fell from a
I
ladder. Was
can't
he on a
remember.
ladder? Or you were talking about
stood
two
up
people on
and
a ladder
fell down.
yesterday?
Yeah, he tripped somehow.
Okay.
Mechanical ground level
Yeah.
fall.
Okay.
And
With heart disease, of course, and other stuff.
we recently, in the last 6 months or so, had a patient who'd had a heart transplant. He was 68 years old. He was riding his motorcycle and somebody pulled out in front of him. So, I mean, that adds a level of complexity that requires a fair amount of expertise in terms of managing.
Right. And see, that
Those
opens up a
patients.
whole nother line of questions for me, right? So you're looking, okay, he needs a heart transplant and he needs it now. And then there is the bank, the heart the organ bank. And we are going to talk about blood in a while too. But
he'd had a previous heart transplant and was living his best life and was on a motorcycle and was injured in a motorcycle crash. And if you look at the irony of that, statistically it's likely that his donor was injured and ultimately was killed in a motorcycle crash. So yeah, there's life has a way of being circular. But the complexity associated with taking care of patients like that, it certainly challenged the healthcare system and us, and hence being at a level 1 trauma center, the likelihood of you surviving that injury despite that what we call comorbidity is much higher.
Right. And I'd like to right now, since we can, and it's part of what's on the table right now, talk about organ donation. I don't want to spend a lot of time on it, but if you are considering that, you can call the DMV, I understand, the Department of Motor Vehicles, I think. If you're interested in doing that, it's always a good thing to do. But Dr. Tyroch, I do want to talk about whole blood. I know that last time we were together on the program, I don't remember exactly, maybe it was Vitalant, but we were talking about the way that blood is processed now and going, you said what's old is new again, what's new is old again.
Correct.
But talk about that. So people who donate blood on a regular basis, and if you haven't and want to, go donate some blood. Somebody can always use it. But what is whole blood? When you hear that now, what does that mean?
What's the whole thing? So in World War I and World War II, a little bit in Korea, a soldier, when they were injured, would get a transfusion from another soldier, or they would bring some blood from the States over there, and they would get basically plasma, platelets, and the packed red blood cells.
Packed red blood cells.
Just the red cells.
Just the red cells.
Just the red cells.
Okay.
Which is the oxygen carrying part of blood, but there's more to blood than just oxygen carrying. You got to clot, and that's the clotting stuff that we have in blood. But blood is a business, so it made more sense to separate it, because some people like that are hemophiliacs, or they have immunosuppression. They may just need the platelets because their platelet counts are low, or they may need the plasma. Some people just need the red cells, so they would separate it. But
so almost everybody that gave blood, most
got
of
separated.
The time, if not all the time, it was separated.
Most likely it was.
Okay.
I can just tell you it was in the 1990s and 2000s.
Okay.
So every time we have a war, we learn stuff, because that's trauma. So when the soldiers went to Afghanistan, to Iraq, they had a hard time getting the blood, the component stuff. So they realized, hey, we have a walking blood bank. The soldiers that are there would donate and they would give to their colleagues. So that's how they started it with the whole blood again. And then when they started coming, the surgeons came back to the United States, they started saying, well, why can't we do this at our own trauma centers?
Right.
People said, no, you can't do that. But they started figuring out ways of doing that. So we've initiated whole blood, and UMC gets about 15 to 17 units of whole blood per week. And we use it.
Okay.
And
so you get it from where? Do you
Vitalant
get it
is who provides it to us.
Gotcha. Okay.
And I can just tell you, and y'all two can chime in, it's a better resuscitative fluid than giving the packed cells. Because now what we do is, okay, we'll give them some packed cells, let's give them some platelets, let's give them some plasma. We try to keep this on what we call a 1-to-1-to-1 ratio, which is hard to do. But now we just get a unit of whole blood, and it's a beautiful bag of 500 cc's. It's really
Dr.
just
Mercer,
robust.
you look like you want to add something to that.
Yeah.
Just
No,
for your body
This is
language.
amazing.
I think that you know, we tend to look at blood and blood products. I mean, if you break it up into components and sell each individual component, then that's certainly associated with greater income for whoever's doing it. And that's been kind of the model that's been used for a good many years, if not decades. But whole blood became more of a logistical issue. And once we could solve the idea of taking whole blood from a patient, not breaking it up, and storing it in such a way that it would last long enough. And of course, we're a big enough trauma center that we don't have an issue with using the blood, the whole blood that's allocated to us. But in respect of what was done in the past, until I came back to UMC in 2023, I had not given a unit of whole blood in my entire career.
Oh, wow.
And I started as a resident at UMC Thomason Hospital in 1980. So it simply wasn't available. So yeah, it was something new to me. But yeah, and you know, to put it into to something of a numerical sense of how valuable it is, people that are resuscitated with whole blood have about a 40% less likely chance of dying as a consequence of their injury.
Oh my gosh. Okay. So if we were looking at the percentage of, let me see how I can frame this question. If Dr. Lasky was going to go give blood tomorrow, is there a questionnaire that says I want to do whole blood donation? Do you want to separate? Like, how does that work in a Vitalant type of a situation? And maybe you know, maybe you don't. I don't know. But I'm asking that question for people who are listening that are curious about this now. I haven't given blood in like 10 years, let's say, or now 5 years. What is that process like now at a blood bank? And this is an unwrapped
I don't know
question.
the answer.
I don't know the answer.
I hope
and
you know, because
totally
I
putting
don't.
you on the spot. I'm sorry about
Well,
that.
I'm glad you asked her.
I haven't worked in a lab
Okay.
for more than 20 years, but when I did, the situation was that the donors don't get to decide. You don't really get to decide if you're going to give whole blood or if you're going to give a component. And the components, like Dr. Tyroch alluded to earlier, are more lucrative to split them up into pieces or parts. So making the plasma and the red cells separate would get you more bang for your buck.
Okay.
And there were also some storage issues in the past. Our technology has improved drastically. And the blood substitutes haven't taken flight yet, but some of them will. And we'll have different types of plasma, like liquid plasma we're talking about. They have lyophilized plasma, or that they can reconstitute. And we even have Cell Saver now, which is used much more often in the OR in the trauma setting than it was when I first started my career, now over 20 years ago. There's times now where we can take the patient's own blood and wash it and give it back to them in better ways than we did before. So a donor doesn't really get to decide.
I get you.
Well, to some extent, the donor does decide based on what their blood type is and their RH. So if you're an O-pos donor, then you're more. I mean, we're more likely to be using your blood or the collection or
That's
the
what
That's very
Vitalant.
true.
Is
The O
O-positive.
blood.
So that's the universal
Yeah, so-
donor, if I
I mean,
remember
it's
right?
for whole
Well,
blood.
O negative would be better, but that's
Okay.
a rare blood
Yeah,
type. So we use O
We use
positive.
O-pos. So
Okay.
effectively, as a donor, if you have O-positive blood, then that's more likely to be used in the whole blood
Interesting.
supply chain.
Okay.
I do think the El Paso region is going to hear more and more about whole blood. Because as we were talking earlier, the state of Texas, we took initiative in 2024 that we want to roll out pre-hospital whole blood across the state, all 254 counties, the small hospitals to have it. And we'll have a process where if that blood is getting old, that small hospital will reciprocate it back to the level 1 trauma center or somewhere.
Right.
But we want that blood out there because it makes
Right.
more. Here's a perfect example. And I use this all the time when I talk about this. Van Horn, Texas, 120 miles from here. It's a level 4 trauma center, Interstate 10. Terrible crashes over there. See those all the time. It takes a while to get here. You can barely get a helicopter out to them because of the distance sometimes where they go. So get some whole blood out to them. They can give the blood as they're being transported to El Paso. So we're going to start hearing about that more. There's some legislative efforts in the state of Texas to put out about $10 million every 2 years to support that. It's now being looked at the federal level. American College of Surgeons just came out, about 6 weeks ago, to say whole blood in the pre-hospital setting is sort of like seatbelts were in the late 1960s,
Gotcha.
saving
Yes.
lives.
And
Yeah.
that comes from the National Highway Traffic Safety Administration study that was recently reported that the impact of pre-hospital whole blood is likely to exceed that.
That just
in
makes
terms
sense,
of
right?
You're thinking
it
saving
through.
lives when seatbelts
It's just the
were
logistics
introduced.
that we got to
You
figure out.
save
Yeah.
blood in the end. You don't have to give as many units to that person that gets the whole blood up front.
Yeah.
And
good
it's also
point.
safer. That person is getting 1 unit of blood from one person. If you do components,
You
it's
have other
multiple
people and then
blood
there's
is
the
still safe though,
process
but
and-
still all that stuff. But
Yeah.
that's what's going to be happening, and it's going to become the standard of care fairly quickly, and it's
Yeah.
already happening.
Well, I'm glad to
That's
talk about it.
exciting.
'Cause I remember when we taled about it last time.
Yeah.
I had
this
no
has
idea what you
moved
were
light
saying.
years
Yeah.
from when we
Okay.
talked. So the other thing to remember with whole blood, it's not just for trauma.
Yeah.
We all use it for cirrhotic patients that are bleeding,
OB patients.
people that are on OB patients. In some places, they're actually using more for them than the trauma population. So
Interesting.
it
Okay.
does save lives.
I'll look forward on doing a program on that.
I think you will hear about
Yeah.
it more.
To be clear, component therapy or component product therapy has a role. We're talking about trauma in our approach to resuscitating people who are in hemorrhagic shock, and shock as a consequence of blood loss. And we're all convinced that whole blood is a better resuscitating fluid. Now, there are patients who, for one reason, who are not injured, who are not in hemorrhagic shock, who may well benefit from component therapy. A patient who has a coagulopathy or can't clot and needs specific therapy, then yeah, that's best given component-wise. Or patients who have a platelet disorder and just need platelets. But from a trauma perspective, from an injury perspective, whole blood is something that we tend to want to use more often.
And that makes sense. That makes a lot of sense. Dr. Lasky, I'm going to ask you, so you specialize in pediatrics, which is great. So I'd love to talk about trauma, pediatrics. Not that I love to talk about it, but we haven't touched base on it yet. So the protocol at UMC for pediatric trauma patients, and I don't even know how to describe that would be. If you want to give a case study or two, that's always helpful for people to understand what you're talking about. But how is UMC equipped for pediatric trauma issues?
So we're an adult trauma center verified by ACS, but we take care of a large number of children. And we have a constant state of readiness for both children and adults. And that is not just this whole village or team that we talked about that runs to the trauma when it's activated. We have the same levels for peds that we do for adults based on their physiology. But with the pediatric traumas, we have that additional layer of support. With the Children's Hospital, we have pediatric intensive care unit doctors, and we have ER doctors that specialize in pediatrics. So we have that layer of extra support. We have child life specialists and
Tell me what
other.
that is. Child life specialists.
Well, it's not my role, but their role is like a social worker, but specific to that patient's family and to supporting them to get back into their former life.
Okay. And this is, again, what I really like about what you all do as a trauma center. It's not just what's happening then. It's about what happens after. And I'd love to touch base on that too, but I feel like we're not running out of time, but I want to get to some very specific things. Yes, please.
About pediatrics stuff.
Yes.
So it's a combined project with El Paso Children's Hospital.
Of course,
It's
that makes
a separate
sense.
hospital, but
Okay.
all is together. So if
Okay.
a small child, we'll move them over to EPCH. We have privileges there, and they have the specialists, as Dr. Lasky mentioned.
There's a
How
few
lovely
things
is
that might be
Yeah.
different, but we basically do airway, breathing, and circulation with the children, just like we do with the adults. But we do our weights in kilograms, and we make sure that all of our child traumas are treated expeditiously. And there's a lot of very specialized equipment based on the size of the child, especially those under 40 kilos. So we have protocols and procedures
And the
specialized to
partnership
that.
with Children's and UMC, like the way that, again, yes, they're in the same building or right in that geographical area, but are there doctors that cross that specialize in both hospitals, for lack of a better
yes.
word? I
All
feel
of our
like-
adult
okay.
trauma surgeons are credentialed over
We take
that's
care
the
of
word I
kids
was
in the
Children's
pediatric
Hospital.
ICU.
Okay.
Yes.
Credential was the word
And
I
the
was looking
pediatric
for.
intensivists will come to the level 1 trauma, pediatric traumas, to help us out if we need them.
We're lucky here.
Yeah.
We're really
it's
lucky
a very
here.
nice relationship.
Dr. Mercer, I'm going to ask you something that I have no idea what this is, but it's ECMO, right?
Yes.
It's the extra corporal membrane oxygenation. What in the world is that? But it's obviously exciting. In February in UMC, this is the first time that somebody had received this life-changing treatment. What is that? Help us out.
ECMO, extracorporeal membrane oxygenation, is a specific technology that's been around for a good many years. Actually, the first patient who was put on an extracorporeal circuit in order to oxygenate the blood because they had injured lungs and allowed the lungs to recover was in fact a victim of a motorcycle crash who had severe chest injuries. And that patient was put on what's called a circuit, where the blood's taken out, run through a pump into an oxygenator and returned to the patient so that we can rest their lungs while the lungs recover. And then we can wean them
So
off
the
of
machine is
ECMO.
doing the oxygenation work for the patient.
Correct.
Okay.
So, and it's been an aspiration here for a number of years, and we brought the program up on January 31st of this year, along with Ivan Garza, who's our director of ECMO, and a very large team of people who are especially trained to take care of a patient on an ECMO circuit. Dr. Lasky and I are two what are called attending ECMO specialists. We also have two attending ECMO specialists in pulmonary critical care as well that work with us. And then we have 24 nurses or respiratory therapists who have experience in ICU.
So talk through what type of patient this would be. So you said earlier that someone whose their lungs are either damaged, or I don't know if this is a lot for little tiny itsy bitsy ones whose lungs aren't really developed yet. But are there types of patients that you?
Well, ECMO has been around. Adult ECMO is what we're talking about. Yes,
Okay.
It has broad application in children and neonates. A little bit of a different
Yeah, that's
approach.
exactly where my head went to
But
immediately.
yeah, so it's been well recognized as an effective modality for a good many years for things that are unique to that population. Now, from a trauma perspective, it's patients who have significant chest injuries, patients who develop pneumonias or adult respiratory distress syndrome as a consequence of their injury or as a consequence of pneumonia that we simply cannot safely oxygenate without further damaging the lungs by using what we would describe as high pressure ventilation. The lungs do not like to be ventilated with high pressure. You get over distension of the little air sacs, and that causes scarring and fibrosis. And although we can ventilate them, 10 years after we get them off the ventilator, we see a fairly fixed incidence of a pulmonary fibrosis that requires lung transplant. So we don't want to do that. So having the ability to put them on an ECMO circuit and let their lungs rest so that we don't have to ventilate them at high pressures in order to oxygenate them or ventilate them at all has been shown to improve survival. If you look at the European literature, patients who are put on a VV or veno-venous circuit for injury have about an 85% chance of surviving. Now, if we had to ventilate a fair number of those patients, the injury to the lung or our ability to even ventilate them without ECMO would
I just think of
would
COVID
be an
every
issue.
time I hear ventilation.
And that's one of the things.
What brought it back.
Okay.
That was one of the things that made ECMO and the model that we use to deliver ECMO a bit different. Prior to COVID, prior to my experience with ECMO started in 2009 in North Texas during the H1N1 flu epidemic in Texas. We developed a program in North Texas. And so I had some experience coming back here. There was an interest in setting up the ECMO program here.
Well, thank you, sir.
Which we were able to do, again, with a lot lot of people involved.
It's very intense.
Yeah.
It's amazing.
I can't even, I'm just trying to picture it too. When you say what it brings to me, it's like when you give the lungs a rest. I mean, that just, you can almost picture that being the case. Just let me do the oxygenation for you and you kind of hang out for a while.
When they put somebody on ECMO, they pretty much live in the hospital, at least the first day or two.
Wow.
It's just so intense.
Yeah.
But there's a crew of people. We'll have a third surgeon joining us. There's some more pulmonologists coming. Tell her where the closest ECMO center outside of El Paso is. I always love to tell people this.
The closest ECMO center outside of El Paso is in Chihuahua, Mexico.
Oh, wow.
So and then the next closest after that is 270 miles away in Albuquerque, and then 365 miles away in Lubbock. In the past, many of our patients who required ECMO would be transferred to San Antonio to Brooke Army Medical Center or Military Medical Center in San Antonio. They would bring a crew in, they would cannulate or put cannulas in that allows us to drain blood off and then return it after it's oxygenated and put the patient on a plane and fly them back to San
Just
Antonio.
think about, we were joking actually before the show of thinking about if we were able to access shows from 28 years ago, just what is so different now. Between then and what will be different, Dr. Tyroch, I would love for you to talk about the Burn Center. And I know there's money, I know there's politics, there's bond issues, there's this, there's that, there's the other.
Bond issue is done,
thank goodness.
But there are always patients.
Yes, there are always patients. And I would love to bring you in too, because did we have a children's burn care unit here, or I don't know.
The nearest burn center is in Lubbock.
You know what? We had a program where somebody came down from Lubbock and we had a program about that, but it was years ago. And I'm looking at you because I remember the little tiny ones that, the photographs were there. But talk to all of us the excitement that's going to be happening. I mean, burn unit, it's so, again, that's time, right? You have an extra hour of transporting someone when they're burnt, first degree burns, et cetera. Talk about why this is so important.
Well, first of all, burns are trauma. It's a type of traumatic injury. We started talking about Jacob Centrone, the CEO, and I started talking about this in 2017. This is how long it took to get this rolling. So we talked about it, and the COVID world hit us, and then we realized we don't have enough beds to do a burn center right. So that's why the bond was so crucial, to give us more ICU beds, give us more ability to actually do a burn unit right. Even though we're not a burn center now, for the last 4 years, we average about 80 to 100 burn patients that meet American Burn Association criteria to go to a burn center. But we try to keep them here because Lubbock is so far away. So we've been managing about 75% of those patients. But this now will allow us to actually take care of bigger burns, more critically in our burn patients. We actually have a burn director coming. Dr. Fiddler will join us in late summer. We get all his paperwork done, which takes forever nowadays. But he will help lead that effort with the trauma surgeons. It's not, once again, it's not just the trauma surgeons, the plastic surgeons, the therapists, et cetera. He's going to be very busy educating all of us how to really take care of a major burn patient.
And throw out some examples of burns. I'm thinking.
Well, let's think about the Metro bus.
Oh my gosh! Yes.
Where they had to go to Phoenix. They were going to go to Lubbock, but Lubbock, the weather was too bad, so they've had to go to Phoenix. And we faced that multiple times where we've had major burns, and we said, let's go to Lubbock. But especially in the wintertime, the weather's so bad, the planes can't fly. You can't use a helicopter. It's too far away, so you have to do what we call fixed wing. But if the weather's bad, we can't get them there. So we had to manage them for days sometimes.
So when you have, if you're saying you have 80 people in your burn unit, what we're
Well, it won't be 80 people
utilizing
at once.
it.
Most of the burns are actually outpatient.
Okay.
Where they'll come in, we take care of them in the emergency room, maybe
Okay.
do something quick in the OR, and they go home the next morning or so. But there will be some that will stay in the ICU.
Okay.
Yeah.
Okay.
But this will allow us to keep these patients here in El Paso, because we bring them to Lubbock, the family goes with them, and they have no place to stay, and then how do they get back to El Paso?
Right.
And we actually did with Dr. Griswold, who's running the burn center there. We do have a teleburn clinic with Texas Tech Lubbock and UMC Lubbock, so they can see the major burns when they're coming back here, when they're repatriated. But this will allow more and more patients to stay in this area.
Okay.
It's one of those things, if you build it, they will come.
Yes.
So we know, that's one of my biggest
Yes.
fears.
Yeah.
It's going to grow too fast.
But you'll have an option. I mean, and that's going to be close by.
It's a good thing. I mean,
Yeah.
so if you look at the top 30 cities in the country, there's only 2 other cities that don't have a burn center in the top 30
Oh, wow.
population. And we're one of them.
Oh, I did not
And
know.
the other ones are very close to a burn center. We're not.
Right.
So
Right.
it's
So this is
something
definitely
the region deserves it.
Yeah.
Yeah, it's time. Just like ECMO, it's time for ECMO.
We have, it's time for, I like that. We have about 10 minutes left and it goes by super fast. But one of my favorite questions that I like to ask is usually what's coming up in the forefront. Trauma is different. So the question is, what is it that you all have had to deal with? And I'm going to ask all 3 of you the exact same question. And I feel like I want to ask you first because you haven't gone for a while, but that puts onus on you and that's not fair. But in your world of working as a trauma doctor, in the medical world, what have you seen that you've been able to fix, for the lack of a better word, that has been life-changing? That's literally one of the questions that I've had. What has impacted your life so much? Because I feel like this type of medicine is like, boom, like what can that be? I'm going to let anyone take it who wants to take it first.
Ladies first.
Oh, that's
happy to speak.
mean. But it's peds too, right? I can imagine there's quite a few really lovely stories there.
Yes, yeah. One of my recent patients reminded me of a lot of things, even though I've been doing trauma for a really long time. You get a sense when someone comes in of whether you think they're going to live or not. And this was a kid that got just torn up in a motorcycle collision. And I didn't think he'd ever walk again, let alone live or survive to make it out of the hospital. But the day he showed up in my clinic walking, smiling, going back to school with a bouquet of flowers, I had to step out of the room because I teared up. I thought, this is why I do what I do.
Yes.
And he's going to have so many more life years ahead of him. He may go to college. He's interested in medical things now. His mother's a nurse. She came back. We've recruited her to UMC.
Wow.
So
You recruited her, so she's now
I
part of
didn't
your
recruit
crew.
her, but she
Very
she
nice.
liked what she saw when
Okay.
she was at our facility. So it's always good to get another talent to come in, a new professional to our facility, and
Yeah.
we love to see that. We want to see people move on and move up, and so he was good for me because he taught me that old lesson that I had learned before and forgotten, that I'm not a higher power. I work for a higher power, and that some people that you think are gonna pass they're gonna live.
And how old was he
it's,
about
you
when
know,
this happened?
He was only 16.
He was 16 when this happened.
Yeah.
Okay. And then look how that came full circle. His mom's now working in the
Yeah,
field.
and here he is, not even 18 yet, having another birthday.
Oh, this
And
is recent
finally,
then. You're talking, this is
Yeah.
very recent.
And finally, here he is back to life again.
Okay.
And kids will surprise you. That's the wonderful thing about young traumas. Trauma's a disease most of the time of the young. A lot of our trauma patients are under 44. Now, we have all these extremes of age as well, but a lot of our trauma patients, trauma is not what people think it is. It's not drunk people that come in all the time.
I love that you said that. Trauma is not what people think it is. So as a doctor, as medical professionals, trauma includes what in your mind, not in the mind of what everybody else is thinking.
Trauma is you and me driving to work. Trauma is somebody trying to get up on a ladder at their house at whatever age. Or trauma may be a kid out on the sports field. Trauma is everyday activity. And it's all ages.
It's all ages, and it's something that can happen in a split second.
And
Dr.
changes their
Tyroch,
life.
You were just talking about someone who, you said you were working last night and somebody fell off of a horse, and there were 2 people that fell off of a ladder. And I think you said there were 9 people in the ER, or so.
And then one guy got stabbed.
And one guy got stabbed. But to your point, it's something that none of us foresee.
Yeah.
It's just something that, and that's why it's called trauma. I'd love to hear what you all have experienced. And I don't know, I think these are things that the audience will leave going, and stories that they'll remember.
Well, I could tell you a couple stories. One was actually just recently happened. I was in a meeting with some other people, and this gentleman walked by. He goes, "You don't remember me." He actually works at the hospital. And I go, "You look familiar." I was like trying to stall, trying to figure it out. He goes, "I was a trauma patient 20 years ago. You took out my kidney. I accidentally got stabbed by some guy and on Donovan."
Oh, geez.
And here he is now. He said, "Y'all didn't think I was going to make it, but look at me." That's the first time I've seen him. I completely forgot about the gentleman. That made my day.
And they're never going to forget your face.
It was just so cool, yeah.
Yeah.
My other one is, actually wasn't a trauma patient, but I was going to see a trauma patient, and as I was going to see this patient, it was a level 2 trauma patient, this lady came in cardiac arrest. She was 23 weeks pregnant, and I had to do what we call a perimortem C-section, which means doing a cesarean delivery. And I remember pulling this baby out that was 23 weeks and looked like this. To be honest, it was pretty scary looking. It looked like an alien. I'm thinking, oh my gosh, what did I bring into this world? And this kid's now 23 years old.
But mom didn't
No,
make
she
it.
didn't make it, but we knew that. That's why it was a perimortem.
Right,
Yeah, but
right.
now we got a 23-year-old. I lost track of her, but I still think of her every year because she's like 4 months younger than my daughter.
Oh my God.
Yeah, it was in January in 2002.
Now that's a story that, I don't know,
Yeah.
I don't think I've ever heard a story like that.
Yeah, I think about every sauce. We all have stories like that, though.
Goodness.
It's really neat.
Dr. Mercer, I feel like it's like, and then we'll add some more.
Yeah, I've been doing this for a long time, and I go to get-togethers and people say, "Describe your worst trauma case," and I go, yeah, "That's not what this is about." And let me switch gears a little bit because I think all of us deal with patients as an individual, and we deal with a lot of them, and we develop a relationship with them individually. But the other piece of trauma is the development of systems that allow us to prevent injury prevention.
Nicely said.
It's not just one patient, it's a population, like our ATV initiative and trying to get helmets for bike riders and kids, and burn centers and ECMO. The ability as us as trauma surgeons to be involved in the creation of systems of care that benefit people, like trauma centers, and make sure that our trauma centers are open and ready. And readiness is a big issue. That's what allows us to deal with the mass casualty events as infrequently, fortunately, as they are. So, and we're involved in that. It's just not the individual patients that we have contact with that we have good results and sometimes not so good results, but systems of care that we recognize have the ability, if done well and done with our input, have the likelihood of improving larger numbers of patients and, in fact, entire communities.
And one of the questions I wanted to ask, and we sort of prepped it earlier, is the stuff that you all learned after the mass shooting at Walmart. And we don't have time to go into it. That's a whole nother thing. But I can almost imagine we learned this, we learned that, we didn't do this right, but now that is a whole nother gamut of things. And I cannot thank you guys enough for being here. I want to tell the audience really quick, in case you just tuned in, or if you are interested in the other programs that the El Paso County Medical Society does. Trauma shows are always so interesting because we always run out of time, because we get stuck on something like the blood. We can talk about blood the entire time. But there are several places that you can rewatch this program. One is PBS El Paso, and that is a .org, because that is a nonprofit organization. But pbselpaso.org, and just find the wording, the El Paso Physician, on there. You actually see the logo on there. You can access this program and the programs that the El Paso County Medical Society does. And that being said, the El Paso County Medical Society website, that acronym is EPCMS.com, and then also YouTube. You can go to YouTube and just look up the word the El Paso Physician, and for the most time, I'll do it, and it will be immediately whatever the last program is that's on. So if you want to watch these programs again, do that. And you may notice that we are filming in a historical home. This is the Turner home, and it belongs to the El Paso County Medical Society. Dr. Turner lived here and then donated it, but it's a Trost-built home. So we're going to be here for quite some time. We appreciate you joining us. Again, this program has been What Happens Inside a Level 1 Trauma Center, and that's what you can look up when you're looking for this program. Thank you so much for joining us. I'm Kathrin Berg, and this is the El Paso Physician.
The El Paso County Medical Society is a nonprofit organization established in 1898 that unites physicians to elevate the health of the El Paso community. We have been bringing the El Paso Physician television program to your home for the last 27 years on PBS El Paso. If you should have any medical questions relating to this program, you may email us at epmedsoc@aol.com, and we will try to have our experts answer your questions.